Hi everyone, welcome to the Stanford GI YouTube channel. I'm Dr. Renu Dhanasekaran, and today I'm joined by Professor Dr. Sinha. He's senior author of a new study from our division published recently in Nature Medicine, where they tested a fasting mimicking diet in patients with Crohn's disease. This is one of the first or the largest randomized controlled trial to rigorously test whether a structured dietary intervention can directly modulate inflammation in the human gut. So thank you so much, Dr. Sinha, for joining us.
Thanks, Renu. It's good to see you, and thanks for having me.
So let's start with what motivated you to do the study, why focus on diet, and why Crohn's disease.
Yeah, happy to do that. So I think the answer to that is what motivates all of us as physicians, and it's really taking care of our patients. And with diet and IBD in particular, what we've seen is there is just a dearth of studies that investigate this. It's hard to study, it's underfunded. Sometimes the financial incentives are not there as they are in pharmacologics, and so we were trying to address one of the most common, if not the most common questions that we see with patients with IBD, and that's what can I eat to feel better, to simply do better and control my IBD.
So for just for our patients here, Crohn's disease is one particular form of IBD, and that you focused on that one, right?
That's right. So IBD is generally thought to consist of two separate diseases. One of them is ulcerative colitis, as the name implies. It involves inflammation of the colon, and the other is Crohn's disease. It's oftentimes a transmural disease and can affect anywhere in the GI tract. And we focused on Crohn's disease.
Okay. So and you also looks like within that you looked at patients with mild to moderate Crohn's disease. Do those patients not already have great treatment options?
Yeah, so that's a really good question. And we chose to study mild to moderate Crohn's disease actually because there seems to be a void in treatment options, particularly for patients with mild Crohn's disease. In fact, in the United States, there are no approved advanced therapies to treat mild Crohn's disease apart from steroids. And as you and I both know, steroids are sometimes the best of drugs, and they can also be the worst of drugs and carry many, many side effects. And so we were looking potentially to provide patients with an adjunctive option. So, in addition to pharmacologic therapy for those who are on it, but also for patients who may not be ready to start pharmacologic therapy, an option for something that they can try a dietary intervention that might impact their care as well.
Sure, yeah, that makes sense. So let's get into the meat of it. What is this intervention, the diet that you studied?
Yeah, so we call this diet a fasting mimicking diet, and it's been studied for many years now, but not in inflammatory bowel disease in particular. And what it consists of is a short cycle of reduced calories, simply speaking, that you take for about 5 days. And you can repeat that cycle more than once. So, unlike most dietary interventions, such as we often hear about the Mediterranean diet, that involves a long-term change in your diet. And for many people, maybe for us, it's easy to think and change our diets to be more Mediterranean-like. But for many people from different parts of the country, different parts of the world, different cultural norms, it can be very challenging to adopt a new diet, and not only adopt the new diet, but stick with a new diet. We all know that compliance and with diets can be very low. So the interesting thing about this intervention, FMD, is it's only a 5 day intervention. The rest of the 25 days or so a month, you eat what you normally eat. In fact, we had our nutritionist and study coordinators contact patients to assure that they didn't change their diet, because in our case, we were specifically interested in studying this particular intervention between the two arms.
Okay, sounds good. So then how was the study designed?
Yeah. So what we ended up doing, as you said, we looked at patients with mild to moderate Crohn's disease, and we conducted a randomized control trial. So that's one thing that's been, lacking in a lot of nutritional studies, but particularly in IBD. And so we did a 2-to-1 randomization. So as you know, that means that two people got the intervention for every one person that was in the control group. And we designed that in particular because when patients choose to participate in a study that involves, collecting samples, coming in for additional visits, getting phone calls, following instructions, etc., we hope that they would get something out of it. And so we were hoping that with the 2-to-1 randomization, we would encourage patients to participate in this study. And despite that sort of design making it harder to actually see a difference in patients, we chose to do that. And even in the patients who were in the control arm, we further tried to, make it fair for them, if you will, by providing them the FMD diet at the end of the study so that they could try that as well. It wasn't a formal crossover study design, but we designed it this way to try and balance out some of the limitations with sort of the duration and cost of the study, but also being able to recruit patients and certainly be powered to assess our outcomes appropriately. And so, what patients did is they would take the 5 day reduced calorie diet. It was something that we mailed to our patients. It's a shelf stable diet that we sent to them. Everything they need to consume for 5 days is provided to them in a box. It's a vegetarian, plant-based diet that they take. That involves, I believe, on day one, it's about 700 or so calories, and then it's about 1,100 calories for the remaining 4 days. And so, as I mentioned, you take that diet. And then the remaining 25 days a month, you eat what you normally would eat. And then we repeated that cycle 2 more times. So for a total of 3 cycles of this 5 day intervention. And then we had specific time periods where we would collect samples, again, trying to sort of balance our desire to understand what's going on scientifically with making this possible for patients to participate in. And then one of the questions we also wanted to see is, well, what are the residual effects of this diet? So we had sort of a later time point too, a couple of months after ending the diet, to see if there were any residual effects from the diet despite you normalizing your diet and stopping this intervention. And our primary outcome in this study was what we call clinical response. So we used a measure called the Crohn's Disease Activity Index, which is commonly used in most pharmacologic trials as an outcome measure to assess interventions. And our primary outcome was to look at clinical response. And we had many secondary outcomes as well, looking at clinical remission, looking at clinical response after just one cycle, looking at psychosocial impacts. In fact, we wanted to look at endoscopic outcomes because that's really the gold standard. Unfortunately, convincing patients to do a baseline colonoscopy and then again doing another colonoscopy a few months later, particularly during the pandemic, was very difficult. But we were able to recruit some patients, and we were limited in the conclusions we could make from the endoscopic data, but everything was in line with our clinical data as well as our biochemical responses that we measured too. So we looked at inflammatory biomarkers such as fecal calprotectin and CRP as well in this study.
Yeah, so that's a very comprehensive, like a gold standard study design for RCT. So that's great. So what were the main clinical results that came out of it?
Yeah, so we were very pleasantly surprised that not only did we meet our primary outcome, so after 3 months, patients had a significant response to the diet in terms of measuring their CDAI and seeing a clinical response, as we defined it, of a reduction of about 70 points. We also saw that after 3 months, that most patients were also in clinical remission. So that means that from a clinical standpoint, their disease was under control. So we weren't able, as I said, to assess endoscopic remission, but we were able to notice that after 3 cycles, patients were in clinical remission. So about 2/3 of the patients in the intervention arm were in remission. Now, I should also mention in the design of this study, we sort of took a real world approach to this. So we allowed patients to continue their standard medical care. So anything that the treating physician wanted to do, they could do during our study. And, I think that was an advantage of this study. And what we found out that the diet seems to work in patients who are already on conventional medical therapy. It also works in the subset of patients who are not on any medical therapy. Now, I wouldn't say to avoid medical therapy, of course. I think this diet would work probably best as an adjunctive therapy. But we saw in subgroup analysis, when we looked at patients who were on no medical therapy, and the difference was essentially this intervention of diet, more patients had a response with the intervention than with the control, and our control being just continuing their normal diet, whatever the patient was taking.
For a non-pharmacologic intervention, I think these effect sizes are quite substantial. So congrats on these results. Beyond the symptoms, I know as a scientist, you've been interested in the mechanisms and how this works biologically. So you did look at many other biomarkers to understand the mechanism? What kind of insights did you gain from those studies?
Yeah, so like a lot of dietary studies, some patients respond, some patients don't. Unfortunately, many of the dietary studies, when you look at the intervention, things kind of wash out. Our main objective, actually, when starting this study, was to try to understand what were some of the signatures, what were some of the characteristics in patients that might help predict response to a diet. And that was sort of a novel way of looking at dietary interventions. And, we were fortunately funded by the Helmsley Foundation, and they understand the importance of looking at some of these mechanistic aspects of a study. So, not purely looking at clinical outcomes, but also trying to understand what is actually going on, so that the same way that we strive to achieve precision medicine with conventional therapies, I think the same thing should be a standard in dietary interventions. And we're hoping that this is an early approach that might be used in the future with dietary studies. So, what we did was collect, as you mentioned, several biospecimens throughout the course of this study. So at baseline and then at various time points, including stool, including blood. We conducted a lot of multi-omic analysis of this. And some of the takeaways that we're seeing here is that, we found that the diet does reduce the effector transcripts of many canonical cytokines that are involved in Crohn's disease. And we also saw that certain lipid mediators, so certain lipid mediators that are derived from arachidonic acid or linoleic acid that are known to be implicated in Crohn's disease and other inflammatory diseases, quite frankly, were significantly reduced with the dietary intervention group compared to control. And so this gives us at least some evidence and some understanding as to biologically what's happening here. And it also lets us try to design future studies where we may be able to even target our intervention further to optimize the results that we might achieve.
That's pretty cool. So there you saw immune reprogramming just with calorie restriction. And I mean the change in the diet. Yeah.
Yeah, exactly. I mean, the diets are calorically restricted and they have certain micronutrient differences compared to other diets. In particular, we're hoping that we generate some sort of ketotic process as well.
True.
And at the end of the day, it could be, and it likely is, that the diet works through pleiotropic effects here. But we're seeing some biologically plausible signals that give us a good understanding of what is going on. And there's other areas, including the microbiome and the metabolome, that we think are also affected. And so we're in the process right now of analyzing some of that data additionally.
Awesome. So was this safe and realistic for patients to follow? Sounds like your patients did fine.
Yeah, that's a great question. The vast majority of patients had no problem following the diet. It's not fun to restrict your calories. If you've ever fasted, you know that it's not a pleasant process. And, if you don't eat a sufficient number of calories, many patients will develop a little bit of fatigue, some headache. But we had no severe adverse outcomes in the intervention group, unlike in the control group, where we did actually have several severe adverse outcomes. And that's because their disease was simply not being treated to clinical remission. So things like abdominal pain and bloody bowel movements, things like that, we saw in the control arm, but we did not see those kinds of things in the intervention arm. So I do think it's a safe diet, like any diet or any change you make in your medical management. I think discussing it with your treatment team is very important. There's certainly populations where I wouldn't advise this diet. If you have nutritional deficiencies, if you're pregnant, if you have other medical conditions that might be impacted by the diet, I think it's not safe to just do this on your own. I think you should always talk it over with your treating physicians and team and make that decision. But overall, we found the diet to be very safe, very efficacious. And most patients, as I said, I think it was about a little over 75%, around 75% were able to take the diet without any issues.
Great. So now it's the big question. You have high quality evidence generated here. So how do you think this can change clinical practice? How are you changing your own practice?
Yeah. So that's a good question. I think we unfortunately while we do have great therapies and there are more and more therapies coming out with IBD as well, we still have many patients who don't respond completely to these things. And I always feel a little nervous sometimes when you got a patient who is 80 to 90% where they should be, right? With an intervention. there's always the risk that you change the intervention, you change the mechanism of action of your advanced therapy, and there's no guarantee that you'll be able to achieve that 80 to 90% again. So that's why I think this is a good example of how we might be able to use diet as an adjunctive therapy with pharmacologics. So I think that's a really nice place to start. Again, I would sort of counsel my patients to sort of think about whether that's something they're interested in, whether that's something they can do, make sure they don't have any medical conditions that might cause harm by doing so. And that's generally how I think is a pretty safe way and first approach based on the evidence that we have to try to bring this into clinical practice. Now, I do think for patients who are not on any pharmacologic therapy, who have mild disease, and there are many patients that despite counseling on the need to start therapy, they simply don't want to do that, right? And so I think discussing this with your physician as well to see if a dietary option might be an option for this population of patients, I think that's a very good thing to also discuss with your physician and make sure that that's appropriate.
Awesome. So what's next? Where are you taking this idea next?
Yeah, so there's a lot of places where we want to go here. I think looking at further exploring the mechanism, as we talked about, looking at changes that we know are occurring in the microbiome and the metabolome, to potentially even understand while we had a very high response rate, not every single patient who took this diet had a response or went into remission. So understanding, which patients might benefit a priori before you start the diet I think would be very important. As I said, it's still 5 days of reduced calorie diet. It's not fun for most people. It's something you kind of push through. I will say, having done the diet myself,
Okay.
that if you can get past the first couple of days, things
Mhm.
get easier. But nonetheless, if you have a high probability of not responding to it, and we can identify those signatures, then maybe another option might be better for you. And I think that we could get there with nutritional interventions and trying to explore these signatures that might help us predict response to diet. I think that's a very compelling area of investigation for many studies. And then I would also say that Crohn's is an immune-mediated disease, and we have reason to believe, based on our results, that this would work as well, if not better, in ulcerative colitis. And
Mhm.
I also think other immune-mediated diseases such as RA, rheumatoid arthritis, I think it could also be of benefit given some of the systemic changes that we're seeing in inflammatory signaling.
Wow, so lots to come. So, okay, thank you so much. But if you had to give one takeaway message for clinicians and then one for patients.
Yeah. So I think for clinicians, and maybe it's the same thing for patients too, it's to be open-minded to dietary interventions, to be cautious when you're interpreting the data and extrapolating what might happen when you engage in a dietary intervention, but encouraging them to utilize this study and try to find patients who might derive benefit from it. For patients, I would say that the best thing is that to follow the medical advice that you're getting with your treating physicians. Consider asking your physicians about dietary interventions, and maybe it's not fasting. Maybe it is simply the Mediterranean diet or a simple carbohydrate diet or other diets that have shown to be effective in Crohn's disease and other immune-mediated diseases. But have that conversation. And if you have the opportunity to participate in a clinical trial, take that opportunity. That's the only way that we'll be able to advance our knowledge and understanding in this area.
Perfect. Congrats again on your study. Thank you so much for joining us.
All right. Thanks a lot, Renu. It's nice to see you and nice to be here.
Thank you.